This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neurology, June 2026 edition, titled Preoperative Imaging Evaluation of Primary Trigeminal Neuralgia using 3D TOF-MRA and 3D FIESTA-c, a retrospective study of 412 cases.
This is a substantial cohort, Ilara, 412 cases. For our residents and colleagues listening, we know that primary trigeminal neuralgia, or PTN, is one of the most common and frankly most debilitating cranial nerve disorders we treat. The pain is often described as electric shock-like or stabbing.
Exactly. And the pathophysiology we generally accept is chronic pulsatile compression of the trigeminal nerve at the root entry zone, or REZ, by adjacent vessels. This leads to focal demyelination and abnormal neural excitability. Because microvascular decompression, MVD, aims to relieve this exact compression, our preoperative imaging has to be spot on.
Right. We're moving past the days of let's open and see what's there. We want to know the responsible vessel, its type, and its spatial relationship to the nerve before we ever make an incision. This study looks at two specific sequences: 3D time-of-flight MR angiography, that's 3D TOF-MRA, and 3D fast imaging employing steady-state acquisition with phase cycling, or 3D FIESTA-c.
It's a retrospective look at patients from January 2017 to October 2025. The authors, Huang et al., used a 3.0 Tesla scanner. They really wanted to see if combining these sequences outperformed using them individually, specifically looking at two criteria: binary identification, meaning is there a vessel or not, and complete concordance, which is whether the imaging accurately identified the exact vessel type found during surgery.
That complete concordance is the real test for a neurosurgeon. It's one thing to say, I see a loop there. It's another to say that's the superior cerebellar artery, or SCA, and have it be true when you get under the microscope. What did the intraoperative findings show as the gold standard?
In 407 of the 412 patients, that's 98.79%, a responsible vessel was indeed identified intraoperatively. Only 5 patients had no responsible vessel found. The SEA was by far the most common culprit, found in 250 cases, which is about 60.68%. Interestingly, the second most common finding was a combination of the SEA and the petrosal vein, seen in 13.11% of cases.
That's a high percentage of venous involvement or multivessel involvement. That's often where imaging struggles. Let's look at the performance of the sequences. How did 3D TOF-MRA hold up on its own?
For binary identification, TOF-MRA had an accuracy of 90.53%. But when you look at complete concordance, identifying the exact vessel, it dropped to 74.27%, with a Cohen's kappa of 0.531.
Which makes sense. TOF-MRA is excellent for depicting high-flow arteries because of the flow-related enhancement, but it can struggle with low-flow vessels or venous structures. What about FIESTA-c?
FIESTA-c performed better. Its binary accuracy was 91.99%, but its complete concordance was significantly higher than TOF-MRA at 82.77%, with a kappa of 0.702. FIESTA-c is great because it provides high contrast between the CSF, the nerves, and the vessels.
It really gives you that cisternogram look where the nerve is a dark structure against the bright CSF. But the real headline of this paper is the combined approach.
Exactly. When they combined 3D TOF-MRA and 3D FIESTA-c, the accuracy for binary identification jumped to 96.36%. More impressively, the complete concordance rate rose to 87.86%, with a kappa value of 0.786. The Cochrane's Q-test showed a significant overall difference between the methods, with a p-value of less than 0.001.
So the message for the residents is, don't rely on just one sequence. The combination is statistically superior. Why do you think the combined approach performed so much better in the SEA and anterior-inferior cerebellar artery, the AICA subgroups?
The paper suggests that while TOF-MRA identifies the arterial anatomy and its course, FIESTA-c excels at showing the spatial relationship and the actual contact point at the REZ. When you overlay that information or view them side by side on the PACS workstation using multiplanar reformation, you eliminate the blind spots of each. TOF-MRA can miss the veins, but FIESTA-c picks up those small dark voids in the bright CSF. Conversely, FIESTA-c might show a vessel, but TOF-MRA confirms if it's actually an artery.
I also noticed they mentioned the limitations of imaging in crowded local anatomy. We've all seen those cases in the posterior fossa where the SEA, AICA, and maybe a few tributary veins are all bunched up near the trigeminal nerve.
Right. In those crowded cases, the combined approach was significantly more reliable. The authors noted that the matching rate for the combined sequences was much higher for the SEA, the most frequent vessel. It really helps the surgeon anticipate whether they are looking for a single loop or a more complex neurovascular bundle involving the petrosal vein.
Let's talk about the 1.21%, those 5 cases where no vessel was found during surgery. Does the paper mention how imaging performed there?
It's a small number, but it highlights that even with high-resolution 3.0 Tesla MRI, we aren't at 100% yet. However, the combined approach reached 96% accuracy, which is a major step forward for surgical planning and patient counseling. If we see a very clear SEA compression on both sequences, our confidence going into the MVD is much higher.
For our listeners who are practicing surgeons, how should this change the preoperative workflow?
The study advocates for the routine use of both. Using the PACS workstation for post-processing is key, specifically multiplanar reformation for FIESTA-c and maximum intensity projection for TOF-MRA. Looking at the axial, coronal, and sagittal planes allows for a 3D mental reconstruction of the REZ.
It's about the pumping effect. We're looking for that pulsatile contact. The paper emphasizes that because PTN is a pulsatile compression disease, the high-resolution nature of these 1 mm slice thickness sequences is non-negotiable.
And the stats back it up. Pairwise comparisons showed that the combined approach outperformed either sequence alone in almost every metric. Even 3D FIESTA-c alone outperformed TOF-MRA when it came to complete concordance.
That's an important nuance. If you only had time for one, FIESTA-c might give you more truth regarding vessel type than TOF, but you'd still be missing that 96% accuracy you get from the combo.
Exactly. The study concludes that the combination of 3D TOF-MRA and 3D FIESTA-c improves preoperative assessment of responsible vessels in PTN, providing higher diagnostic accuracy and better agreement with intraoperative findings.
It's a great reminder that as our imaging technology advances, our surgical precision should follow. We're no longer just looking for contact, we're looking for concordance.
A perfect way to sum it up. 412 cases, a 96% accuracy rate with combined imaging, this study provides solid evidence for our preoperative protocols.
Well, that's all the time we have for today's deep dive into the Journal of Neurology. I'm Dr. Aris.
And I'm Dr. Alara.
We'll see you next time on the Neurosurgery Hub podcast. Keep learning and keep operating.